So good morning everyone. Hopefully all the audiovisuals are fine. So let's discuss about the remaining questions which are most expected in the upcoming FMG examination. So this is the last part of the session. Do recommend it to your friends also. Those who have missed this, these sessions will be on my YouTube channel for the next few days. So even if they have missed it, they can watch it at a speed of 1.5x later on. Okay? Chalo bache. Good morning everyone. Hopefully all of you are doing well. Okay, chalo. So all of you should have gotten up until now because your examination is going to be at this point of time. Those who are not awake, so please make sure that you should be awake by this time and you should start solving questions every day, daily basically. Yes, beta, you can revise the rapid revision once. Basically, it will be much easier for you then to catch up. Okay, so yes, you can get basically my subscription if you want only for surgery. You can contact me on my Telegram handle, Instagram handle, anywhere. I can share you basically where you can get my recorded videos. Okay, chalo. Great. Now let's start without any further delay. Be active in the chat box as I always say. ठीक है बेटा? चलो, let's start. So now the next question basically is question number 76 that says a middle-aged patient was brought to you with complaints of chronic abdominal pain along with vomiting and diarrhea. On per abdominal examination, a mass was palpable in the right iliac fossa, which is suspected to be a carcinoid tumor. Now they are asking you that which metabolite levels should be checked in the patient's urine sample. So one thing is we all know that here they are talking about a mass in the right iliac fossa. We know in the right iliac fossa we have the ileocecal junction or we have the appendix, and we know it is going to be more likely a case of appendicular mass or a appendicular tumor. If they ask you which is the most common appendicular tumor, I hope all of you are quite aware the most common appendicular tumor are carcinoids beta, right? Carcinoids are neuroendocrine tumors, and these carcinoids are commonly seen at the ileocecal junction or in the appendix, as well as they are also seen in the bronchus. The two common sites for carcinoid tumors, one is the ileocecal junction in GI tract and second is the bronchus in the lungs. Clear? So carcinoids are going to be the most common type of appendicular tumor. Whenever there is a carcinoid tumor, patient may develop a serotonin syndrome. These carcinoids secrete excess amount of serotonin, and that is the reason why the patient is having features like diarrhea beta. Right? We know serotonin syndrome में patient will have features like wheezing, flushing and diarrhea. ठीक है? Any condition which is causing serotonin syndrome. Serotonin syndrome is seen with neuroendocrine tumors, either like carcinoid tumors or medullary thyroid cancer. ठीक है? Now here, if they say that which metabolite level should be checked, so any patient who is having more amount of serotonin in the body will have more amount of 5-HIAA, that is option B, 5-hydroxyindole acetic acid in the urine beta. ठीक है? So whenever serotonin is metabolized, the metabolite is known as 5-HIAA. So whenever there is serotonin syndrome or a tumor like carcinoid, do remember check for the 5-HIAA levels in the urine. You will find those are going to be elevated. This was a recent FMG question, so be aware of that. For carcinoid tumors, yaad rakhna, whenever the tumor is less than 2 centimeters in size or it is more than 2 centimeters away from the base, then in this condition I have to just remove the appendix. That is known as an appendectomy or appendicectomy. So here we will only do a simple appendectomy or a simple appendicectomy. Nothing else is required. But if the size of the tumor is more than 2 centimeter or the tumor is less than 2 centimeters from the base, it is within 2 centimeters from the base, then in this condition I have to remove the whole right half of the colon, and that is called as a right hemicolectomy beta. That has to be the treatment. Hopefully clear. Now do remember, if they ask you metanephrine, yesterday itself I've told you that metanephrine levels in the urine are going to be elevated in patients suffering from pheochromocytoma. So if it was a case of pheochromocytoma, mass is not in the right iliac fossa, as I've told you yesterday. Mass is going to be in the lumbar region or in the flank. That is one thing to be remembered. Clear? Secondly, copper porphyrin levels in urine you check for cases of lead poisoning. And phenylketones, so all of you are quite aware, phenylketonuria is the condition where you check the phenylketone levels in urine of the patient. Clear? So do remember this. And drug of choice for serotonin syndrome is cyproheptadine. That was a recent NEPG question. Drug of choice for serotonin syndrome is cyproheptadine. Clear? Next, if I talk about question number 77, here we are having a 19-year-old male who was brought to the emergency room with recurrent episodes of intussusception. Okay, on performing surgery, polyps were identified in the jejunum. Histopathological examination of the polyp is shown below. They are asking you what is the type of polyp which you are able to see in this condition. So I'll come to the provisional diagnosis. You will tell me the answer of this question, whether it is an adenomatous polyp, inflammatory polyp, hyperplastic polyp, or hematomatous polyp. What kind of polyp it is? First is, we know a teenager or a adolescent patient who is coming to you. Secondly, that patient is having recurrent episodes of intussusception, and when we tried to find out what is the cause of intussusception, we were able to find out polyp. We know primary intussusception happens due to hypertrophy of Peyer's patches, right? Primary intussusception in children less than 2 years of age, that happens due to hypertrophy of Peyer's patches in ileocecal junction. But secondary intussusception happens due to problems like polyps or tumors, right? So here there was a polyp in the jejunum of the patient, and histopathological examination of the polyp is shown. You can see finger-like projections are seen, beta, and this pattern is classically known as the filigree pattern or the ferning pattern, whatever you want to call it as. So do remember, this pattern which you are able to see of the polyp on histopath is classically known as the ferning pattern, arborizing pattern, filigree pattern, whatever you call it as. Okay, the ferning, filigree, arborizing pattern is seen. And we know adolescent patient with multiple polyps in the jejunum with ferning pattern on histopath is a classical diagnosis of Peutz-Jeghers syndrome, right? We know this condition, Peutz-Jeghers syndrome, it's due to the STK11 gene mutation. So serine threonine kinase or STK11 gene mutation, which follows autosomal dominant pattern of inheritance, is the cause for a patient of Peutz-Jeghers syndrome. That is one thing to be remembered. Secondly, we know Peutz-Jeghers syndrome increases the risk of multiple cancers, but maximum risk is of pancreatic cancer. Peutz-Jeghers mainly increases the risk of pancreatic cancer. That has to be kept in mind. The risk of pancreatic cancer in Peutz-Jeghers syndrome increases by 100 times almost. Clear? Whereas the classical feature in patients of Peutz-Jeghers syndrome are these blackish or brownish spots that you are able to see on the lips or around the oral cavity, and these are known as perioral melanosis or lentigens. So the most characteristic or most pathognomic feature of Peutz-Jeghers are these perioral melanotic spots or lentigens which are going to be seen. Hopefully clear. So I hope all of you might have answered the question until now. What is going to be the answer for this question? Just a minute. Very good. All of you are basically right, beta. In cases of Peutz-Jeghers syndrome, the type of polyp that we see is option D, that is a hematomatous polyp, right? Please tell me another condition which is due to the P10 gene mutation where there are multiple hematomatous polyp. So hematomatous polyp in the intestine are seen in two conditions. One is Peutz-Jeghers syndrome, which is due to STK11 gene mutation. Second is which condition which happens due to the P10 gene mutation? Let me know in the chat box. Do remember, out of all these polyps, if they ask you the most dangerous polyp or the most malignant polyps, answer is adenomatous polyp. So highest risk of malignancy, if they ask you it is seen with which polyp, answer is the adenomatous polyp, especially the Willis variety. So the Willis variety of adenomatous polyp are going to be the most malignant or the most dangerous. Clear? Inflammatory polyps are usually associated with ulcerative colitis. Inflammatory polyps, also called as pseudo polyps, they are commonly seen with ulcerative colitis and they are not pre-malignant in nature. Hyperplastic polyps are the most common type of polyps. Okay, hyperplastic are the most common type of polyps and they are also not pre-malignant. Clear? Apart from that, there are other two conditions which increases the risk of colorectal cancer. Peutz-Jeghers syndrome increases the risk of colorectal carcinoma, but along with that, one is FAP, that is familial adenomatous polyposis, which increases the risk. It happens due to the APC gene mutation. So familial adenomatous polyps has more than 100 adenomatous polyps in the intestine. That's the reason there is a 100% risk of colon cancer or colorectal cancer. and it happens due to the APC gene mutation. Whereas another recent question in the FMG exam was about HNPCC. HNPCC is a hereditary non-polyposis colon cancer, and this hereditary non-polyposis colon cancer is a part of Lynch syndrome, and it happens due to the mismatch repair defect or the MMR defect. Okay, in the recent examination they gave the option as MMR. It happens due to the mismatch repair defect or the MMR defect. Hopefully clear to all of you. What is that another condition that you were able to understand? That is Cowden syndrome. Do remember the other condition which happens due to the P10 gene mutation, which also has hematomatous polyp, is known as Cowden syndrome. And Cowden syndrome increases the risk of three cancers. BET we call it as BET BET. ठीक है, तो Cowden syndrome increases the risk of BET cancers beta, B for breast cancer, E for endometrial cancer, and T for thyroid cancer. So breast cancer, endometrial cancer, and thyroid cancer risk increases with Cowden syndrome or due to P10 gene mutation. Do remember that point? Recent NEET PG it was. Next is question number 78. This we have discussed. We are having a 3-day-old child who was brought to you with a greenish yellow discharge from the umbilicus. Now, I hope all of you are quite aware, whenever a neonate is brought to you with a greenish yellow discharge, what is this discharge going to be? So, do remember, this discharge is basically going to be meconium, bache. This discharge is commonly going to be meconium. So here it is more likely to be a case of a meconium coming out from the baby's umbilicus. And we know, when will meconium come out from the baby's umbilicus? Meconium will come out from the umbilicus if the gut or if the GI tract is connected to the umbilicus. I hope all of you are quite aware, during the fetal life, there is a connection between the midgut and the umbilicus, and that connection between the midgut and umbilicus is known as the vitellointestinal duct or the omphalomesenteric duct. That connection between the midgut and the umbilicus is known as the vitellointestinal or the omphalomesenteric duct. If this vitellointestinal duct or if this vitelline duct, if it is completely open or if it is completely patent, then in those conditions, patient develops a vitelline fistula, and in this vitelline fistula, we know the meconium or this greenish yellow discharge will be coming out from the baby's umbilicus. So whenever they say greenish yellow discharge or meconium discharge happening from the umbilicus, we know it is a case of vitelline fistula, and vitelline fistula happens due to option D, a persistent and a patent vitelline duct or a persistent and patent vitellointestinal duct. Hopefully clear to all of you. Do remember, persistent urachus leads to formation of a urachus fistula, and yesterday itself I've told you that urachus fistula may not the meconium but urine will come out from the baby's umbilicus. That is important. Meckel's diverticulum, it is due to a patency of the vitellointestinal duct, but in Meckel's diverticulum the vitellointestinal duct is only partially patent, not completely patent, one thing. And second, it will not cause any greenish yellow discharge or meconium discharge from the umbilicus. Okay, it is just an outpouching from the gut or outpouching from the intestine, that's it. No discharge happens in Meckel's diverticulum. Intussusception does not happen due to persistence, or it will not cause any greenish yellow discharge. Clear? Intussusception will cause the red currant jelly stools, not any greenish yellow discharge. Okay? We know vitellointestinal duct, if this structure is going to be persistent and patent. So do remember, there are two problems which will arise. First, the partial patency of the vitellointestinal duct will give rise to an outpouching called as Meckel's diverticulum, okay, which is 2 feet proximal from the iliocecal junction, as I've told you yesterday. Secondly, the complete patency of the vitellointestinal duct gives rise to a condition known as vitelline fistula, and in this vitelline fistula itself, meconium discharge happens from the umbilicus. Clear? Whereas if I talk about second embryological structure known as urachus, so yaad rakhna, urachus is a connection in the fetal life between urinary bladder and umbilicus. Okay? If this urachus is actually going to be patent, then if there is a partial patency of the urachus, then it leads to formation of a bladder diverticulum. So bladder diverticulum is going to develop if the urachus is partially patent, but when the urachus will be completely patent, that gives rise to a problem known as urachus fistula. And I've told you that in urachus fistula, urine comes out from the baby's umbilicus. That has been a PYQ. Clear? So these are the points that you need to remember. Next important is question number 79. Here they say, we are having a 5-year-old child who was brought to you with complaints of chronic constipation. Now they are saying, after taking stool softeners, the patient or the child is able to pass the stool. ठीक है, तो after taking stool softeners, the patient is able to pass the stools, and history reveals that the child also had a delayed passage of meconium at birth. The child also had a delayed passage of meconium at birth. Which of the following shall be carried out in this condition? So I hope all of you are quite aware. Whenever they say no passage of meconium at birth, or whenever they say delayed passage of meconium at birth, in those conditions, what we do? We know normally meconium should pass within 48 hours of birth, and urine should pass within 24 hours. But if meconium haven't passed even within 24 hours of birth, we call it as delayed passage of meconium. For that, we do a DRE, or a digital rectal examination. And when we do a DRE in the neonate and I stimulate the rectum, please remember, on performing DRE or on stimulating the rectum, if there is passage of stools beta, we know it is a classical diagnosis of Hirschsprung's disease. Okay, it is a classical case of Hirschsprung's disease, also called as congenital megacolon or congenital aganglionosis. Whereas, even after stimulation of rectum or even on DRE, if there is no passage of meconium, then it is a diagnosis of cystic fibrosis. Reason we know, in cystic fibrosis, the meconium will be extremely hard, and that's the reason even on DRE, the meconium does not flow out. Clear? So that is what is important. So after stimulation, if the meconium passes, it is a case of Hirschsprung's disease. We know Hirschsprung's basically happens due to the absence of ganglionic cells from both the plexuses, Meissner's plexus as well as the Orbach's plexus. So when there is absence of ganglionic cells from Meissner's as well as Orbach's plexus, that is Hirschsprung's. Commonly, Hirschsprung disease affects the rectosigmoid area. Commonly, Hirschsprung's disease affects the rectosigmoid area, and as ganglionic cells are absent, or as the rectosigmoid area is collapsed in Hirschsprung's. That's the reason the baby is not able to pass the meconium, or baby is not able to pass stools, causing constipation. Clear? We know in cases of Hirschsprung's disease, the best investigation that we use is a rectal biopsy. So when you do a rectal biopsy, beta, obviously that is going to confirm the diagnosis. It will tell you whether the ganglionic cells are present or absent. Rectal biopsy is the best investigation. But apart from that, you can even do a barium enema in the patient as well. If you want to know the extent of disease, you have to go for a barium enema. Okay? And treatment, we know in Hirschsprung disease, whatever part of intestine or whatever part of GI tract is aganglionic, you have to resect that part and join the remaining part. That is resection and anastomosis. The surgeries for resection and anastomosis are Duhamel's operation, Swenson's operation, or the Sovan-Park surgery. So Duhamel, Swenson's, and Sovan-Park's, these are the surgeries done for a case of Hirschsprung's disease. Clear? So here there is a 5-year-old child with chronic constipation, and here they are saying that the child is only able to pass the stools after taking stool softeners, and there was a delayed passage of meconium at birth. So we know either it could be a case of Hirschsprung's or it could be a case of cystic fibrosis beta. More commonly, it seems to be Hirschsprung's. You will be like, why? Reason, in cystic fibrosis, apart from meconium ileus or delayed passage of meconium, they should also talk about other features like lung infections, sinusitis, pancreatic insufficiency or malabsorption. No features are seen over here. So it more commonly seems to be a case of Hirschsprung's disease if only GI features are there. Okay? So here definitely beta we think about Hirschsprung's as the case. Now they have asked you what is going to be carried out in this case. So option A says surgical resection. Yes, we will carry out surgical resection, but not immediately. First, let us confirm the diagnosis whether it is a case of Hirschsprung's or not. Option B says continue stool softeners. You're not going to keep the patient on stool softeners lifelong, na bhai. You have to treat the condition, and for that you need to diagnose the condition first. Option C says plain X-ray abdomen. It is not a case of bowel obstruction. If it was a case of bowel obstruction, then my first line investigation is a plain X-ray abdomen. Option D says barium enema and manometry. Yes, among all the following options, the answer has to be a barium enema and manometry. So the first investigation that I'll do is a barium enema and manometry. Manometry say I can definitely measure the pressure in the rectosigmoid area as well. Okay? So barium enema and manometry will be done, and after that, to confirm the diagnosis, you will go for a rectal biopsy, and after that, you can go for the surgical resection with any of these surgeries. Clear है बात? चलो. Next important, if I talk about now, hopefully everything is fine. ठीक है? चलो. Keep on answering in the chat box. Now, next is question number 80. Here you are able to see a case beta. They are asking you to identify the type of perianal fistula that is given in the picture below. Now, We know for perianal fistulas which is there, we are going to have the Parks classification. So do remember there is a Parks classification that we have for perianal fistula. Here in the picture you can see this is the internal anal sphincter, this is an external anal sphincter, this is the dentate line, okay? And the black one is the fistula. The first one you are able to see here, the fistula is actually going in between both the sphincters. We know whenever the fistula goes between both the sphincters, it is classically known as the intersphincteric fistula, which is the most common type, and this intersphincteric fistula is also known as the type 1 fistula. Clear about? Whereas if I talk about the second one, here you are able to see that the fistula is crossing both the sphincters. Whenever fistula crosses both the sphincters, we know it is known as a transsphincteric fistula, also known as a type 2 fistula. Is a transsphincteric or a type 2 fistula. Next important, this is the fistula where you can see the fistula goes above the sphincters. We know whenever the fistula goes above the sphincters, it is a suprasphincteric fistula. It is a suprasphincteric fistula, and suprasphincteric fistula is a type 3 fistula. And last one, here you can see there is a fistula which is above the outside the sphincters. Whenever there is a fistula which is outside the sphincter, we know it is an extrasphincteric fistula. And do remember that extrasphincteric fistula is a type 4 fistula as well. Hopefully clear to all of you. Out of all of them, if they ask you commonest one, that was a PYQ. We know the most commonest type 1, that is the intersphincteric fistula. यहाँ पे if you see the picture, you are able to classically see there is a fistula which is going between the two sphincters. That is the most common variety called as type 1 or intersphincteric fistula. So this is a classical picture of option A, that is an intersphincteric fistula or a type 1 fistula, which is nothing else but the most common variety as well. Okay, it is the most common variety that has to be kept in mind. We know when I talk about perianal fistula, patient will come to you with complaints of perianal pain along with pus discharge per rectum. And in perianal fistula, they have asked you the name of rule that is used. For perianal fistulas, the rule that we have is known as Goodsall's rule. According to Goodsall's rule, anterior fistulas are going to have a straight track, whereas posterior fistulas will have a curved track. Anterior fistulas have a straight track, whereas posterior fistulas have a curved track. But this is only applicable for those anterior fistulas beta which are usually in the 3 centimeter range from the midline. So from the midline, any fistula that is from 11 o'clock to 1 o'clock position, or any fistula that is 3 centimeters from the midline, only for those kind of fistulas this Goodsall's rule will be applicable. Okay? Whereas if they ask you investigation of choice, another PYQ, it is a MR fistulogram. A T2 weighted MRI is done for the fistula. So MR fistulogram is the investigation of choice for perianal fistula. If MR fistulogram is not an option, mark MRI as the answer. Clear? And treatment, we know any fistula that opens above the anorectal ring is a high fistula. Any fistula that opens below the anorectal ring is a low fistula. For all the high perianal fistula, go for a set-on thread insertion. You have to insert the set-on thread and keep on tightening the set-on thread, which breaks the fistula. Whereas for low perianal fistula, either go for a fistulotomy or a fistulectomy. Okay, fistulotomy to open the tract or fistulectomy to remove the tract. Clear? Next is question number 81, which says we are having an alcoholic patient who presented to us with complaints of severe abdominal pain radiating to the back along with distension and features like fever and vomiting. Okay, so patient was having a severe abdominal pain. The patient is an alcoholic having a severe abdominal pain radiating to the back, a classical feature. CECT scan reveals there is a echoic lesion with fluid collection near the body of pancreas. So I hope all of you are aware what is the diagnosis more likely going to be. Alcoholic patient having abdominal pain radiating to the back or epigastric pain radiating to back. This pain worsens when the patient lies supine, and this pain is relieved when the patient bends forwards. Clear? A classical feature. And we know echoic lesions are basically seen on CCT with fluid collection near the body of pancreas. So we know it is a case of nothing else but acute pancreatitis. The classical diagnosis is acute pancreatitis. We know in acute pancreatitis, if they ask you what is the leading cause or what is the most common cause, so yaad rakhna, the leading cause or the most common cause for acute pancreatitis, answer is going to be gallstones. So gallstones are the leading cause for acute pancreatitis, whereas The second most common cause is alcohol. Gallstones are the leading cause, whereas second most common cause is alcohol. याद रखना. In cases of children, this was another PYQ. In children, what is the leading cause for acute pancreatitis? So we know it is a blunt trauma. Okay, so blunt abdominal trauma due to bicycle handle injuries. So blunt abdominal trauma is the leading cause for acute pancreatitis in children. That was a PYQ one liner. Clear? याद रखना, in cases of acute pancreatitis, investigation of choice is CECT abdomen. I have told you, best radiological investigation for any retroperitoneal organ, it is CECT abdomen, whether it is pancreas or kidneys. Clear? कोई भी condition हो. Now here they have asked you that what is going to be the marker that is going to be elevated if you are suspecting acute pancreatitis. We know the best investigation to confirm the diagnosis of acute pancreatitis is option B. That is nothing else but serum lipase beta. That has to be kept in mind. Hopefully all of you are able to answer this. So please make sure that you are answering in the chat box. ठीक है, तो serum lipase is going to be the best investigation to confirm the diagnosis of acute pancreatitis, followed by serum amylase. Yes, serum lipase is better as compared to serum amylase. Reason is lipase is going to be more specific for acute pancreatitis. Amylase, which is there beta, it is not very specific because amylase is elevated in other conditions too. So best one is going to be serum lipase followed by serum amylase. Clear? Serum CEA or a carcinoembryonic antigen. Do remember, carcinoembryonic antigen is actually a tumor marker for colon cancer or pancreatic cancer. So in colon cancer or pancreatic cancer, the CEA or carcinoembryonic antigen will be elevated. GGT is gamma glutamate transpeptidase. It is usually elevated in liver diseases. So GGT is usually elevated in alcoholic liver diseases, and bilirubin, it is also elevated in liver diseases itself or gallstones. Clear about? So that is what is important to be remembered. So here they have not spoken about any jaundice. So serum bilirubin, we won't find it to be elevated. Here the cause for acute pancreatitis is more likely going to be alcohol. So as such, bilirubin may not be elevated. They have not said any jaundice also. So do remember that. Okay? And do remember, treatment in patients of acute pancreatitis is usually a conservative management. And I've told you, conservative management means keep the patient nil per oral, give IV fluids, IV antibiotics, and analgesics for pain relief. That is what is given. Clear? Now, identify this surgery. Let me know the name in the chat box. Let me know the name. This has been a previous year question which have been asked. Just by showing the picture, they ask you what is the name of the surgery. Let me know. Anybody, what is the name of the surgery that you are able to see? I'll just tell you the indication of the surgery. This surgery is generally done for a pancreatic cancer, especially those pancreatic cancers which are seen in the head of pancreas or which are seen in the periampullary region. So any pancreatic cancer that is seen in the head of pancreas or of periampullary region, for them we go for this kind of a surgery. That is a big hint now. ठीक है? Hopefully all of you are able to answer the question. It is not a Roux-en-Y surgery exactly. Yes, it is a type of pancreatico-jejunostomy, but not a Roux-en-Y exactly. What is the better name for this surgery? Let me know in the chat box. So here you can see beta that we have removed the head of pancreas, we have removed the duodenum. So it is a pancreatico-duodenectomy. Along with pancreatico-duodenectomy, we have also removed the common bile duct and we have removed the gallbladder as well. Clear about? So here you can see we have done three anastomosis. One is a pancreatico-jejunostomy that is done. First is a pancreatico-jejunostomy. Second is a hepatico-jejunostomy or a choledoco-jejunostomy. Whatever is possible, whether a hepatico-jejunostomy or a choledoco-jejunostomy, and third one is a gastro-jejunostomy. So three anastomosis have been done, and this is a classical surgery done for pancreatic cancer known as Whipple's. Yes, this is a Whipple's procedure or a pancreatico-duodenectomy. So this is a classical picture of Whipple's surgery or a Whipple's procedure. Do remember that has been a previous year image-based question in both FMGE and NEET PG as well. Okay, so this is a Whipple's surgery, and if they ask you what is the most common complication of Whipple's, तो याद रखना the most common complication of Whipple surgery is the impaired gastric emptying. ठीक है? So a delayed gastric emptying or impaired gastric emptying is the commonest complication of Whipple's and the most common cause of death after Whipple's. It can be cardiovascular complications or anastomotic leak. two leading causes of death after Whipple surgery. It is cardiovascular complications and the anastomotic leak. Clear? Chalo. Next, question number 82. We are having a 25-year-old alcoholic male who presents to us with complaints of epigastric pain and fullness which radiates to the back. So again, the patient is having abdominal pain or an epigastric pain which is radiating to the back. Again, classically suggestive of pancreatitis. But here now on examination, they are saying that the lump is palpable in the epigastrium. Okay? So a lump is palpable in epigastrium. So CCT done has been given below. What is the treatment? Now, if you look at the CCT abdomen of this patient, you are able to see there is collection of fluid in the abdomen, or there is collection of fluid in the epigastrium basically, and this happens as a result of pancreatitis. So the patient had a pancreatitis earlier. After that, there is collection of fluid in the lesser sac of omentum. Okay? The most common site, if they ask you for this collection of fluid, so do remember the most common site for this collection of fluid is the lesser sac of omentum. So we know whenever there is pancreatitis and followed by which there is collection of fluid in the lesser sac of omentum causing epigastric pain, fullness, vomiting, it is a classical feature of a pancreatic pseudocyst beta, right? We know it is a classical diagnosis of a pancreatic pseudocyst. Okay, classical case of a pancreatic pseudocyst. And do remember, majority pancreatic pseudocysts are smaller in size and they are going to spontaneously resolve. अपने आप ठीक हो जाता है. Majority of them they spontaneously resolve, but there are few pancreatic pseudocysts which do not resolve timely, and if they do not resolve, they may keep on growing in size, and for them we need to go for treatment. The majority show a spontaneous resolution, but if this rule of 6 is there, that means if the size of cyst if the cyst is for more than 6 weeks duration, if the size of cyst is more than 6 centimeters, or if the wall thickness is more than 6 millimeter, so whenever the pseudocyst has been more than 6 weeks old, more than 6 centimeter in size, or more than 6 ka wall thickness hai, so in those conditions you have to go for a treatment, that is surgery. And that surgery is nothing else but you have to drain the cyst, you have to drain the fluid collection, you have to drain the cyst. Either go for an external drainage, that is done with the help of ultrasound guided pigtail catheter, or go for a internal drainage. Internal drainage is preferred, that is a cystogastrostomy or a cystoenterostomy. So here, as we have option B, cystoenterostomy in the option, to go for that. So yaad rakhna, here for a pancreatic pseudocyst, the best answer will be an option B, that is a cystoenterostomy, that is draining the cyst into intestine. Okay, so this is an internal drainage. If that was not an option, another option could be an ultrasound guided pigtail catheter insertion, not a needle aspiration, a pigtail catheter insertion and drainage. Okay, but preferred is the internal drainage. Conservative management is not done because it is symptomatic or it is large in size. That's the reason conservative management will not be done. Surgical excision is not required. Hopefully clear. Chal. Next important, if I talk about, is question number 83, a common confused question. All the time people keep on sending me this again and again, because yes, this question has been given wrong, the images are wrong basically at a lot of sites, and sometimes they're not wrong, but the classification that they use, that is different. That's the reason the problem happens. Now yaad rakhna, according to the European Hernia Society classification beta, any hernia that is seen in the umbilicus, or any hernia that is seen in the periumbilical region, that is within 2 to 3 centimeter, all of them are considered as umbilical hernias only. समझे बात? According to the European Hernia Society classification, all the hernias in this region are umbilical hernia. So if you find even this hernia marked as umbilical hernia beta somewhere, that is because the classification that they tend to use is European Hernia Society. Because in European Hernia Society classification, there is no term of paraumbilical hernia. There is no term paraumbilical hernia. Every hernia in this region will be umbilical according to that classification. But clinically, we can classify them as umbilical and paraumbilical. So if you have to identify, तो यहाँ पे देख सकते हो, here there is a herniation from the umbilicus of the patient, and here you can find that the umbilicus is everted. Umbilicus बाहर आया हुआ है बेटा. So whenever you find basically that the umbilicus is everted or the umbilicus is coming out, we know that the herniation is actually forming from the umbilicus itself. Whenever you find that the umbilicus is everted, We know it is nothing else but a case of option B, an umbilical hernia. Then what is a paraumbilical hernia? Paraumbilical hernia is this one. Can you see? This is, I am going to call it as a paraumbilical hernia. You will be like, why? Reason is, do remember here, the umbilicus is not everted. Okay, there is no eversion of the umbilicus that you are able to see. First point. Okay, no eversion is going to be seen of the umbilicus. That means the umbilicus is intact. There is no eversion at the level of the umbilicus. And secondly, the umbilicus forms one of the boundary of the hernial sac. Whenever the umbilicus forms one boundary of the hernial sac, and if there is no eversion of the umbilicus, that is a classical picture of a paraumbilical hernia. Hopefully clear to all of you now. Okay, so that is what is important. Do not get confused with this question. याद रखना epigastric hernia is any herniation basically that happens from the midline of the abdomen. Any herniation from the midline of the abdomen, especially from that linea alba. Any herniation from the midline of abdomen or the linea alba is known as epigastric hernia. Next is Pegalian hernia. We know Pegalian hernia is any herniation which happens from the lateral border of rectus abdominis. ठीक है, तो any herniation that basically happens from the lateral border of the rectus abdominis muscle, it is known as a Pegalian hernia. And do remember, Pegalian hernia has a very high risk of strangulation. Pegalian hernia has a high risk of strangulation that has to be kept in mind. Apart from this, one more abdominal wall hernia is a incisional hernia. So if the herniation happens from a previous scar or a previous incision, that is an incisional hernia. Clear? All of these are abdominal wall hernias, and these ventral hernias or abdominal wall hernias. What is the treatment? If the defect is going to be small in size, that is around 1 to 2 centimeters, then go for a Mayo's repair. If the defect is small in size, that is around 1 to 2 centimeter, go for a Mayo's repair. Mayo's repair is a type of herniorrhaphy, that is closing the defect with sutures. Whereas if the defect is large in size, so in larger defects, we cannot go for a herniorrhaphy. We have to go for a hernioplasty surgery, that is a mesh hernioplasty. So here we are going to close the defect with the help of a mesh. Clear about? So in a PYQ, they have asked a 70-year-old patient comes to you with complaints of a swelling arising from the umbilical region, and the defect size was found to be around 12 centimeters. What is the management? Does not matter if the patient is elderly, but if the hernia is symptomatic, if it is causing problems, beta, you can go for a surgery considering the patient was not having any other diseases or any other comorbidities. Okay, so if the patient is not having comorbidities, if the defect of the hernia is large in size, if the patient is symptomatic, you need to go for a surgery. And there were two options. One was hernia repair with mesh, another was hernia repair without mesh. So we know a large defect like 12 centimeter, we will always go for hernia repair with mesh beta. Clear? So that is important. Understood? Next is question number 84. Here they are saying which one of the following is not an absorbable suture. Let me know in the chat box now. Which one of the following is not an absorbable suture? That means they are asking you which one of the following is a non-absorbable suture. Which one is not an absorbable suture? Basically, let me know in the chat box. Option A is polyglactin. Option B is polypropylene. Option C is polydiaxone, which is also called as PDS. And option D is catgut. So I hope all of you are quite aware about this condition. If they ask you which is the non-absorbable suture, very good, all of you are right. Shabash. So we know beta that polyglactin, which is there, it is another name for your vicral suture. Polyglactin is another name for your vicral suture, and we know vicral suture is generally used for viscera, that is bowel and bladder repair. So whenever you have to go for a bowel and bladder repair or any viscera, then is the condition where we use the polyglactin suture or the vicral suture. Do remember, vicral is a absorbable suture. Next is polydiaxone. Polydiaxone, another name is PDS. Polydiaxone, another name is PDS. Do remember, PDS is also used in the same conditions, that is viscera, yeah, bowel and bladder. Same as vicryl, you can use it. Okay, this is also an absorbable suture. Vicryl is going to be absorbed within 60 to 90 days. The absorption time for vicryl suture is around 60 to 90 days, whereas the absorption time for PDS or polydiaxone is 180 days. The absorption time for PDS or polydiaxone is around 180 days. Next is catgut suture. We know catgut suture is also used for the viscera itself, and this catgut suture which is generally used for the internal organs of the viscera, do remember this is going to be absorbed within 60 days. So within 2 months or within 60 days, the catgut suture is going to get absorbed. Clear about? So here the answer has to be option B, that is polypropylene, which is another name for Prolene suture. So polypropylene is another name for the Prolene suture, and we know Prolene suture is a non-absorbable suture. So answer has to be option B. So do remember, if they ask you absorbable and non-absorbable ka classification, one is absorbable sutures, which will get absorbed within few days. Non-absorbable means the sutures which will not be absorbed and we have to cut them or remove them after few days. Second classification is natural and synthetic beta. Natural means those sutures which are derived from plants and animals, and synthetic means those sutures which are going to be artificially derived. Okay, those sutures which are going to be artificially prepared. Now here, if I talk about the absorbable sutures and the natural sutures, the absorbable natural sutures will be catgut and chromic catgut. So catgut and chromic catgut are absorbable as well as natural sutures. Second, if I talk about the non-absorbable natural suture, so do remember there is only one non-absorbable and natural suture, that is silk. So silk is a natural suture and it is non-absorbable in nature. If I talk about absorbable synthetic sutures, so do remember the absorbable synthetic sutures, if they ask you, it is vicryl, monocryl, and PDS, that is polydioxone. So vicryl, monocryl, and polydioxone, these are absorbable sutures and they are synthetic in nature. Whereas lastly, if I talk about, it is the non-absorbable synthetic sutures. So non-absorbable synthetic sutures will be proline and nylon. So proline and nylon both are synthetic sutures and they are non-absorbable in nature. That has to be kept in mind. Hopefully clear. Next, if they ask you about the suturing techniques, we know the first one, you can see the suture is taken, only one bite of a suture is taken, and then we are tying a knot, and then we are cutting a suture. Then the second bite is taken. So here you can see only one bite is taken at one point of time, so it is a simple suture. Second, you are cutting the sutures basically, that means it is an interrupted suture. The recent question in the FMGE exam, image based. Clear? So this is a classical picture of a simple interrupted sutures beta. So this technique which is there, it is known as simple interrupted sutures. Whereas second picture which is there, here you can see once we have tied a knot, after that we will keep on taking bite after bite after bite basically, and we are not tying the knots in between. We are not cutting the suture in between. Whenever you are not cutting the suture in between beta, we know it is classically known as a simple continuous suture. This is a classical picture of a simple continuous suture. And do remember, simple continuous sutures will have a very high risk of slippage. The very high risk of slippage is basically seen with the simple continuous suture, has to be remembered. No issues with this. Clear about? So do remember, this proline or polypropylene suture is generally used for nothing else but your vessels. So for vascular surgery or for vessels, definitely we tend to use the proline or the polypropylene suture. Do remember that point. Next is question number 85 about the instruments. Now here they are asking you, identify the below given instrument. Let me know what is the name of this below given instrument beta. Options are: A is Spencer Wells straight artery forceps, sorry, Spencer Wells artery forceps. Second, B is Kocher's forceps. Third, C is Ali's forceps, and D is Babcock's forceps. If you see the forceps closely, we know it is a forceps because it is having this locking system called as ratchet. So a forceps has this locking system or ratchet and a box joint over here. This is basically a forceps having some curved blades beta. And if you look at the end of the blades properly, you'll find one end is concave and another end is convex, right? So one end is concave and another end is convex basically. This is a classical picture of which forceps. Let me know in the chat box. I hope all of you are quite aware. Very good, all of you. Yes, the answer to this question is nothing else but option B, that is Kocher's forceps. The answer has to be Kocher's forceps. We know Kocher's forceps are generally used for the procedure like ARM. We know whenever you have to do a ARM or artificial rupture of membranes for induction of labor. For induction of labor, when you do ARM, you tend to use the Kocher's forceps. Secondly, whenever you have to do crushing of tissues, for crushing tissues, you commonly use the Kocher's forceps. We know Spencer Wells artery forceps basically will not have these kind of concave and convex end basically beta. It does not have any kind of concave or convex ends. That is important. Ali's forceps which is there, it is a curved forceps. Okay, it is going to have curved blades and it is going to have teeth, or it is going to have sharp edges so that it can hold tough structures basically. Whereas Babcock's forceps, it is going to have curved ends and it is going to hold delicate structures or hollow structures. Okay, if you see the picture, so these are the instruments that you're able to see. The first one, This one you can see beta. This is the classical forceps. This is nothing else but a Spencer Wells straight artery forceps. Okay, so this is the Spencer Wells straight artery forceps that you are able to see in the picture. Second one, if you see, this is classically known as the Wrigley's forceps, also known as the outlet forceps. So whenever you have to do sorry, instrumental delivery or a forceps delivery, for that forceps delivery, you tend to use this Wrigley's or the outlet forceps. This has been a PYQ again. Next one is the Valsalem or the Valsalem forceps. So whenever during a biopsy, when you have to hold the cervix, to hold that cervix, we use this Valsalem forceps beta. That has to be remembered. Next is this Mayo's towel clip. This one that you are able to see is a Mayo's towel clip. So to fix the surgical drapes during surgery, we tend to use this Mayo's towel clip. Next, if I talk about these forceps over here, you can see the shortest artery forceps that we have, the smallest artery forceps that we have beta, it is known as the mosquito forceps. The smallest artery forceps is known as the mosquito forceps. It can be straight blade, it can be curved blade, that is important. Okay, it is generally used for dissection of tissue. Next, this is again a straight artery forceps that you are able to see, a Spencer Wells straight artery forceps it is. Next, this is the classical Alice forceps beta. This is the classical Alice forceps. If you see properly, it will have the sharp edges, or it will have the teeth basically, so that it can actually hold the tough structures whenever you have to hold any kind of tough structures. Whereas the last one, this was a PYQ, this was the Babcock's forceps. This is a Babcock's forceps, and if you see, Babcock forceps is basically having curved ends and it is having fenestrations. Okay, it is having curved ends and it is having fenestrations. It is generally used to hold the hollow structures or the delicate structure. It is generally used to hold the hollow or the delicate structures. That is important. Next, this is the classical feature of a Doyen's retractor. So this is the classical Doyen's retractor, and we know Doyen's retractor is generally used to retract the urinary bladder. So whenever you have to retract the urinary bladder beta, in those conditions, we have to use the Doyen's retractor. So in lower abdominal surgeries or lower segment cesarean section, whenever you have to retract the urinary bladder, you tend to use the Doyen's retractor. That has been a PYQ, so be aware of that. Next, this reverse L shape that you are able to see. This reverse L shape while retractor is known as Langenbach's retractor. So this is the Langenbach's retractor that you can see. And the next one, just a minute. The next one that you are able to see, which is having a square blade or which is having a very broad blade. The square or broad blade while a retractor is Morris retractor. याद रखना, Morris retractor is generally used to retract solid organs or large organs like liver. In cholecystectomy surgery, whenever you have to retract liver, you tend to use this Morris retractor. Hopefully clear. Chalo. So that is what is important. Next, let's talk about question number 86, a Sarkari easy question of the FMG exam. A patient has undergone a superficial parotidectomy surgery, they are saying, for a parotid tumor. The patient has undergone a superficial parotidectomy for a parotid tumor like pleomorphic adenoma के लिए, ठीक है. Now they are saying few weeks after the surgery, patient complains of sweating and flushing over the cheek every time he eats the food. So whenever the patient eats food, especially spicy food beta, he immediately gets sweating and flushing over the cheek or sweating and flushing over the parotid region, as you're able to see in the picture. So they are asking you what is the likely nerve damage during the surgery. So we know the provisional diagnosis of this case is nothing else but a case of Fraser syndrome. I hope all of you are quite aware. After a parotidectomy surgery, if a nerve injury happens and due to which the patient is having sweating and flushing over the cheek every time he eats the food, is a classical diagnosis of Fraser syndrome. And if I talk about Fraser syndrome, do remember that Frey syndrome में the most common nerve that is damaged is which one? Option A says greater auricular nerve, B says lingual nerve, C says cauda tympani nerve, D says auriculotemporal nerve. So I hope all of you are quite aware. This is a classical case of nothing else but answer is option D, that is your auriculotemporal nerve, right? So please remember the answer is option D, that is an auriculotemporal nerve. So auriculotemporal nerve, if it is damaged during the parotidectomy surgery, याद रखना the classical diagnosis is Fraser syndrome. ठीक है? Option A, if they ask you, do remember greater auricular nerve. Yes, greater auricular nerve may be damaged during the surgery, and whenever greater auricular nerve is damaged in the surgery, patient has loss of sensation or patient has anesthesia over the angle of jaw. So during a parotidectomy surgery, greater auricular nerve can be damaged, and if there is damage to the greater auricular nerve after few days of surgery, patient complains loss of sensation or anesthesia over this angle of jaw while shaving. That is a common PYQ again. Okay, so greater auricular nerve injury will cause anesthesia over the angle of jaw. Lingual nerve is not damaged in parotidectomy surgery. Lingual nerve is damaged in granular surgery or floor of mouth surgery, and that causes loss of general sensations from anterior two-third of tongue. Clear? Chorda tympani nerve, again, it is not commonly damaged during parotidectomy surgery. Okay, so chorda tympani nerve, if it is damaged, patient will have loss of taste sensations from the anterior two-third of the tongue. Clear about? So here it is the auricular temporal nerve injury which causes this phrase syndrome, and the treatment is you can give an injection of botulinum toxin to kill those aberrant fibers. You can give injection of botulinum toxin. Do remember, during a parotidectomy surgery, yes, auriculotemporal nerve can be damaged, greater auricular nerve can be damaged, but the most common nerve that is damaged, do remember, it is neither the auriculotemporal nerve nor the greater auricular nerve. The most common nerve injury that happens during a parotidectomy surgery, answer is MMN, that is marginal mandibular nerve, which causes drooping of angle of mouth. Yes, so do remember, the most common nerve that is injured basically during the parotidectomy surgery is neither the auriculotemporal nor the greater auricular nerve. Answer is answer has to be MMN, that is marginal mandibular nerve. That is important. Okay. The most common nerve injury during a parotidectomy surgery is marginal mandibular nerve. That has to be kept in mind. Done with this. Next is a question, that is question number 87. They are asking you, here the patient has been brought to you after a road traffic accident to the casualty and his hemodynamics are unstable. Obviously, the patient is hemodynamically unstable. That means the patient's BP will be low and the heart rate will be high. So that means the patient will be in shock. He was diagnosed with a class 3 hypovolemic shock. So here the patient is suffering from class 3 hypovolemic shock. They are asking you, what is the percentage of blood that is lost from his body in a class 3 hypovolemic shock? So this was a PYQ and FMGE examination. Do remember, we know the most common type of shock is hypovolemic shock, also known as hemorrhagic shock. And in hypovolemic or hemorrhagic shock, there are 4 classes. You have to remember the percentage of blood loss just by the tennis scores. Okay, in tennis we give scores as 0, 15, 30, 40 and okay, game over. So in similar manner, class 1 hypovolemic shock mein the percentage of blood loss is 0 to 15%. Class 2 hypovolemic shock mein percentage of blood loss is 15 to 30%. Class 3 hypovolemic shock mein the percentage of blood lost is around 30 to 40%, and this was the question. Whereas in class 4 hypovolemic shock, the blood lost is more than 40%, that is game over. Clear? We know in class 1 hypovolemic shock, all the hemodynamics are stable beta. The pulse rate, systolic BP and urine output, everything is normal in class 1. In class 2, compensation starts, and that's the reason in class 2 the pulse rate or the heart rate will start rising. So if they ask you pulse rate starts rising, in which class of hypovolemic shock? Answer is class 2 or mild shock. Do remember, class 2 is known as mild shock, class 3 is known as moderate shock, and class 4 is known as severe shock. So pulse rate or heart rate starts rising in class 2 or mild shock. Next, another PYQ. Urine output starts decreasing. In which class of hypovolemic shock? So systolic BP and urine output both start decreasing in class 3 hypovolemic shock or moderate shock. So in class 3 or moderate shock, systolic BP and urine output both will start decreasing beta. Clear? Whereas in class 4 hypovolemic shock, the pulse rate and the systolic BP becomes non-recordable and the urine output is almost negligible beta, or the urine output is almost absent, that is anuria. Clear about? So here if they ask you answer, so it is 30 to 40%. The closest option which is there, it is option C, that is 35 to 40%. So yaad rakhna, in the examination at times you will not have the exact same value. You have to find the closest answer possible. So 0 to 15% is class 1, 25 to 30% it is basically class 2, 35 to 40% can be included in class 3, more than 50% would be class 4 obviously. Clear about? And do remember one thing, I'm again and again telling this every platform I go basically, and that is a lot of people I've seen making a mistake when the name of the shock changes. So if they say basically about obstructive shock, yaad rakhna beta, whenever they're talking about obstructive shock, they mean that in which shock the circulation is going to stop or the flow of blood stops. The answer is cardiogenic shock. In cardiogenic shock, which can happen due to heart failure or due to arrhythmia or due to congestion or due to cardiac tamponade. So please remember, in these conditions of cardiogenic shock, there is obstruction to the flow of blood. And as there is obstruction to the flow of blood, we call cardiogenic shock as an obstructive shock. Whereas if they talk about distributive shock, so distributive shock means those shocks where the blood gets distributed in the periphery. So in the shocks, wherever the blood is distributed in the periphery. Why? There is a peripheral vasodilation, and due to that peripheral vasodilation, all blood gets distributed in the periphery. So venous return decreases, thereby cardiac output and blood pressure also decreases. So examples of distributive shock, if they ask you, one is basically going to be an anaphylactic shock. In anaphylactic shock, due to allergies, there is release of histamine, and histamine causes peripheral vasodilation. Whereas second is neurogenic shock. In neurogenic shock, due to loss of sympathetic activity, again there is a peripheral vasodilation. So in anaphylactic or neurogenic shock beta, due to that peripheral vasodilation, all the blood gets usually distributed in the periphery. So these two are also considered as an example of distributive shock. Hopefully clear to all of you now. So do remember this point अच्छे से. ठीक है? So that is what is important to be remembered. Understood? Next, if I talk about now question number 88, they are asking you all the statements regarding the Wilms tumor are true except, I hope all of you are quite aware that Wilms tumor is also known as a nephroblastoma, right? Wilms tumor is also known as a nephroblastoma, and they are asking you which statement is false or which statement is incorrect. That is the question. That is the one that we have to find. We know beta Wilms tumor, also known as nephroblastoma, is going to be the most common intrarenal malignancy in children. Okay, do remember the most common intrarenal malignancy in children. If they ask you, answer is going to be Wilms tumor or nephroblastoma. In adults, the most common intrarenal malignancy is renal cell carcinoma. The most common renal malignancy in adults is renal cell carcinoma, but in children, it is Wilms tumor or nephroblastoma. Okay, and it is commonly associated with Beckwith-Widman syndrome. Beckwith-Widman syndrome has hemihypertrophy, umbilical hernia or omphalocele, macroglossia, and Wilms tumor. These are the features. That was a PYQ in August. Okay, so do remember that. Now here they are asking you. Option A says Wilms tumor is the most common intra-abdominal malignancy. No. Do remember, most common intra-abdominal malignancy is a neuroblastoma, not a nephroblastoma or Wilms tumor. It is the second most common intra-abdominal malignancy. So याद रखना, most common intra-abdominal malignancy is a neuroblastoma in children, followed by nephroblastoma or Wilms tumor. That has to be kept in mind. Option B says early lung metastasis is seen. No, but early answer. Yes, early lung metastasis will be seen in Wilms tumor. So renal cell carcinoma and Wilms tumor, both of them basically they will cause an early lung metastasis, and that is classically known as the cannonball metastasis. So cannonball metastasis to the lungs is commonly seen either due to renal cell carcinoma or Wilms tumor, and second due to choriocarcinoma. Both of them cause a cannonball mets to the lung. Option C says treatment is surgery followed by chemotherapy. Yes, so a surgery followed by chemotherapy in early stages and surgery followed by chemoradiation in the latter stages is the treatment of a Wilms tumor or nephroblastoma. Option D says commonly a hematogenous spread is seen. Yes, we know commonly Wilms tumor spreads by the hematogenous route basically. So yes, we know option A, that is most common intra-abdominal malignancy. No, it is not the most common. So that is an incorrect or a false statement. The answer is option A to this question. Hopefully clear to all of you now. Next is question number 89. Here they say we are having a young patient who was brought to you with complaints of urine retention along with hydronephrosis, and the below given intravenous urogram is going to be seen. What is the likely diagnosis? Sarkari picture of the FMGE exam among the intravenous urograms. So we know. So here they are saying there is a urine retention along with hydronephrosis. Okay? And the intravenous urogram is shown below. And on that IVU, you are able to see a very classical feature or a very classical appearance. You can see that the ureteric opening or the ureteric orifice will be narrow, And as the ureteric opening or orifice is narrow, therefore the ureters are not able to drain the urine, and that is the reason there is urine retention or there is hydronephrosis, as you are able to see. Okay, so here, as there is a very narrow ureteric opening or narrow ureteric orifice, the intramural part of ureter is dilated, and that gives you a very classical cobra head or a adder head appearance. The dilated intramural ureter gives you a very classical cobra head or an adder head appearance, and we know cobra head or adder head appearance on an intravenous urogram is a very classical feature of nothing else but a condition known as option B, that is uretrocele. All of us are quite aware. Answer is option B or uretrocele. Do remember, though in examination they give bilateral uretrocele commonly, but normally the incidence of unilateral uretrocele is much more common. Yes, commonly uretroceles are unilateral. In few cases they are going to be bilateral. Second, if I talk about treatment, तो treatment के लिए either you can give an incision at the ureteric orifice to make an incision and make the ureteric opening bigger so that urine can drain, or do a reimplantation of the ureter, make a new opening or create a new opening for the ureter, that is reimplantation of ureter can be done. Clear? Retrocaval ureter means whenever the ureter goes behind the inferior vena cava, whenever the right ureter goes behind the IVC, that is known as retrocaval ureter. It also causes urine retention, and in retrocaval ureter, the IVU will classically show you a fish hook ureter or a reverse J-shaped ureter. So fish hook ureter or a reverse J-shaped ureter is a feature of retrocaval ureter. Another is ureteric stricture. This is how the ureteric stricture is going to look like beta on the intravenous urogram. If you see the picture, here you will find that there is obstruction to the flow of urine. The ureters have become extremely narrow, and that's the reason urine is not able to flow out, causing retention of urine or hydronephrosis again. Okay? Please tell me what should be the treatment if the patient is suffering from a ureteric stricture. You are able to see the treatment also in the opposite side. What is this treatment basically that we are doing? What we are inserting? So whenever there is ureteric stricture, what is this that we are going to insert? I hope all of you are quite aware. Whenever there is a ureteric stricture, to open up that ureteric strictures, the treatment is a DJ stent or a double J stent. Okay, so we have to insert a DJ stent or a double J stent. In a recent NEET PG examination, they gave a X-ray for a DJ or a double J stent, but there was no option of DJ or double J stent. So the another name is cysto-ureteroscope. We know the DJ stent or double J stent is also known as a cysto-ureteroscope. एक ही चीज होती है वो, ठीक है? Do remember that. In ureteric TB, there is a gall-full ureteric orifice that is seen. Here, there is not a gall-full ureteric orifice. There was a cobra head or a adder head appearance. The answer is option B, uretrocele. Next is question 90. Here they say a patient presents to you with complaints of flank pain that is radiating to the perineal region. One thing, if they say there is only flank pain or there is only lumbar pain, then I will think about kidney stones or renal stone. If there is only flank pain which is not radiating, then we have to think about kidney stone or renal stone. But if they say that there is a flank or a lumbar pain which is radiating to some area beta, if there is a flank or lumbar pain which is radiating to the perineal region or the scrotum, the inner thigh, or the iliac fossa, if the flank pain or lumbar pain is radiating to any of these sites, then it means it is a ureteric stone. Yes, the stone or the calculi is inside the ureter then. And they have also given the X-ray KUB, as you are able to see in the picture. They are asking you what is the most appropriate treatment for this. Here, if you see, this is the classical picture of the ureteric stones. Okay, there are multiple stones in the ureter, not one, but rather multiple stones are there in the ureter of the patient. So we know the provisional diagnosis of this case is ureteric stones, or you can call it as a ureteric calculi. Okay, here the diagnosis is nothing else but ureteric stones or ureteric calculi which are going to be seen. And whenever there is ureteric stone or calculi, I hope all of you are quite aware what is going to be the treatment. Option A says ESWL or extracorporeal shockwave lithotripsy. So we know here we use shockwaves and we break the stone into multiple pieces. Okay? So that extracorporeal shockwave lithotripsy or ESWL is generally used for renal stones beta, and especially those renal stones which are more than 5 to 6 mm in size. It is generally used for renal stones or kidney stones, especially those ones which are more than 5 millimeters in 5 to 6 millimeter in size. Next, if I talk about URS, yes, URS is ureteroscopic removal of stone. So you are going to insert a ureteroscope, and then with the help of a Dormia basket, you are going to remove the stone from the ureter. Yes, that has to be the answer. Answer is option B or URS, that is ureteroscopic removal of stone with Dormia basket to be done, beta. Okay, it is done usually whenever the stone is in the ureter and whenever the size of the stone is more than 5 to 6 mm, or whenever the stone is impacted. In both these conditions, so whenever the stone is large in size, more than 5 to 6 millimeter, or whenever the stone is impacted, in both these cases, अगर impacted stone छोटा भी हो तो भी निकालना है फिर, ठीक है. तो if the impacted stone, even if it is small, then also we have to remove it, ठीक है. Next is PCNL, that is percutaneous nephrolithotomy. In percutaneous nephrolithotomy, you directly extract the stone from the kidneys or the pelvis. So PCNL is also a procedure done for renal stones. PCNL is also a procedure done for renal stones, but it is done when ESWL is not possible. And we know ESWL is not possible whenever the stone is large in size, more than 2 centimeter, or whenever there is some distal obstruction. Let's say there is an obstruction in the urethra or somewhere. ठीक है, तो याद रखना, whenever there is a stone more than 2 centimeters in size or there is a distal obstruction, we know the procedure is PCNL for the renal stones to be done. Observation is generally done for a ureteric stone or a kidney stone whenever it is less than 5 to 6 mm in size. The observation is done for smaller stones which are less than 5 to 6 mm in size, whether in the kidneys or in the ureter, does not matter. We have already discussed the most common type of urinary stones. When I talk about urinary stones, I talk about both, that is whether it is a renal stone, that is nephrolithiasis, or a bladder stone, that is cystolithiasis. The most common urinary stones overall are calcium oxalate stones. I've told you they are seen in patients of hyperoxaluria, and calcium oxalate stones cause pain and hematuria. Calcium oxalate stones are known to cause pain and hematuria. Clear? Next, if they ask you about question number 91, that states a patient presents to the OPD with complaints of chronic right upper quadrant pain or a chronic right hypochondrium pain. Along with that, there is icterus or jaundice, along with malaise. Malaise is a generalized weakness that we have. Ultrasound done has been given below. They are asking you what is the likely causative agent of this condition. So yaad rakhna, if there is chronic right upper quadrant pain, along with jaundice, along with generalized weakness, it can be some condition related to the liver or the gallbladder. Here, definitely, if you see beta at the ultrasound which is given, on the ultrasound, you are able to see there are multiple fluid filled collections, or there are multiple fluid filled cysts that you are able to see inside the liver. And we know whenever there are fluid filled collections or fluid filled cyst inside the liver, it is more likely to be a case of hydrated cyst beta. It is more likely to be a case of hydrated cyst that has to be kept in mind. Okay, you will be like, why not abscess? Usually abscess is a uniloculated collection, basically that is one cavity seen commonly for abscesses. But yes, cysts which are there, they are multiloculated. Okay, cyst can be multiloculated. Abscesses can be multiloculated, but that is less common, basically. Clear about that is important. And abscesses usually have fever also as a important complaint. ठीक है, तो here definitely it is more likely to be a case of hydrated cyst, and I hope all of you are quite aware. Hydrated cyst is commonly seen in liver, but it can also happen in other organs like the lungs. ठीक है, it can also happen in lungs. Hydrated cyst is commonly caused by dog tapeworm, and we know that dog tapeworm is known as echinococcus. We know it is caused by a dog tapeworm known as echinococcus. Let me know what is the answer. Option A says Clostridium difficile, option B says Echinococcus granulosus, option C says Entamoeba histolytic, and option D says Echinococcus multilocularis. What is the answer for this case? So we know basically, yes, it is nothing else but D, not B. That is the common mistake that you may do, basically, and that is the reason I have included this question. I knew this was a PYQ beta. Here you are not able to see a single cyst beta. Here you are able to see multiple cyst or multiple hydrated cyst inside the liver. Whenever there are multiple hydrated cyst, or whenever there is a case of malignant hydrated, then the causative agent is not Echinococcus granulosus. Then the causative agent is option D, that is Echinococcus multilocularis. By the name it is evident, Echinococcus multilocularis. So here there is a multiloculated or multiple cyst which are going to form. ठीक है, single cyst होता तो my answer would have been Echinococcus granulosus. Okay, if there was a single hydrated cyst in the liver, then my answer remains Echinococcus granulosus. This has been a PYQ. Do not get confused again. Clear? Clostridium difficile is a organism or a bacteria known to cause pseudomembranous colitis. We know after taking broad spectrum antibiotics, if the patient develops diarrhea, that condition is pseudomembranous colitis. which is caused by organisms like Clostridium difficile, for which we give drugs like fidaxomicin or vancomycin. I've told you earlier also. Do remember that. Entamoeba histolytica is known to cause amoebic liver abscess basically. Okay? Now we know for a case of hydrated cyst, we basically use a ultrasound or a CCT abdomen as the investigation of choice. Do remember one rule that I've told you: for all abdominal problems in children, the investigation of choice is ultrasound abdomen, whereas for all abdominal problems in adults, the investigation of choice is CCT abdomen. ठीक है? तो बच्चों में अल्ट्रासाउंड abdomen करते हैं, adults में CCT abdomen करते हैं. मेजॉरिटी abdominal problems में याद रखना ये रूल, ठीक है. But the best investigation to confirm the diagnosis is an ELISA or immunoblot beta. Best investigation to confirm the diagnosis is ELISA or immunoblot. Whereas we know we have two classifications that are there for a case of a hydrated cyst. One is known as the WHO classification, second is known as Garbhi's classification. Now, if there is a single hydrated cyst, as you are able to see in this picture, and in that hydrated cyst, if you find there is a detached membrane or there is a floating membrane inside the cyst, we know it gives you a very classical water lily sign or a floating water lily sign. So this water lily sign or serpent sign, which is due to the detached membrane, classically comes under the WHO stage CE3A or the Garbhi's classification type 2. It comes under the WHO stage CE3A or the Garbhi's type 2 basically. Hopefully clear. And we know the treatment for a hydrated cyst is usually albendazole plus pair therapy. If there is a single hydrated cyst, go for albendazole along with pair therapy. Pair therapy is percutaneous aspiration, injection of scolicidal agents, and reaspiration. So you have to aspirate all the fluid from the cavity or the cyst and then inject scolicidal agents and then reaspirate the scolicidal agents also. ठीक है, do remember that. But अगर multiple hydrated cyst है बेटा, for multiple hydrated cyst the better option is a liver resection. For multiple hydrated cysts, the best treatment is a liver resection. Here pair therapy is not usually recommended. ठीक है, so that is what is important. तो यहाँ पे treatment अगर पूछा होता तो my answer would have been liver resection, not a pair therapy, because there were multiple cysts. Hopefully clear. Chalo. Next is question number 92. Here you are able to see a 20-year-old male who presents to you in the emergency with complaints of a sudden onset pain in the right inguinoscrotal region. On examination, the right testis is higher up in position. That is a keyword. Whenever the testis gets pulled up or whenever the testis is higher up in position and there is tenderness on palpation of the testis, what will be the next step in this condition now? I hope all of you are quite aware about the diagnosis. Please tell me what is this condition. Whenever they say a very young patient, that is a 10 to 25-year-old male, comes to you with complaints of a severe pain in the scrotal region or in the inguinoscrotal region and the testis is pulled up or it is higher up in position. Okay, we know this classical diagnosis is a case of which condition? Very good. Yes, shabash. So it is a classical case of nothing else but testicular torsion, beta. It is a classical case of a testicular torsion whenever the testis or the spermatic cord is twisted or it is malrotated. That is a case of testicular torsion, and we know in testicular torsion, as the spermatic cord is twisted, the testis will not receive enough blood supply, so it may undergo ischemic necrosis. The testis will get necrosed beta in this condition. We know in testicular torsion, usually the diagnosis is clinical. Based on signs, symptoms, and the clinical findings, you can confirm the diagnosis. But some cases may you can use an ultrasound or a Doppler to assess the status of the testis. That means if you want to see the testis is viable or not, for that you can also do an ultrasound or a Doppler at times. But mainly the diagnosis is clinical. That means even if ultrasound is not available, you can directly go for a surgery. Do remember. And treatment, we all know it is a surgical exploration. You will start finding the testis, and when you start the surgical exploration, if you see that the testis is viable, that means testis has not undergone necrosis yet, you have to go for a derotation and orchidopexy. Pexy is a fixation. Okay? So if the testis is viable, do an orchidopexy after derotation. And if the testis is non-viable, means the testis has already undergone necrosis. So if the testis is necrosed, then you have to remove the testis. That is an orchidectomy. If the testis is non-viable, then you have to remove the testis. That is known as an orchidectomy basically. Hopefully clear. So do remember this point. So यहाँ पे let's rule out the procedures first. First is option D says Jabulé surgery. Option C is herniatomy. We know whether it is Jabulais surgery or a herniatomy, both these procedures are done for hydrocele. Whenever it is a congenital hernia, we tend to go for a herniatomy procedure. Whereas if it is a large hydrocele, we tend to go for a Jabulais surgery. Okay? So hydrocele is collection of fluid inside the scrotal sac, but we know hydroceles are usually painless. Okay? So herniatomy or Jabulais, both are done for hydrocele. Next, orchidectomy. Yes, orchidectomy may be done in cases of testicular torsion, but that will be decided once we do a surgical exploration. So the first step in this condition has to be option A, that is surgical exploration beta. So surgical exploration will be done first, and then if the testis is non-viable, then we will remove it, that is orchidectomy. Hopefully clear to all of you now. That is important to be remembered. Yaad rakhna, to differentiate testicular torsion from epididymoorchitis, we perform a French test. The French test is done to differentiate a torsion from epididymoorchitis. Clear about? Next is a case which says, question number 93, where a child has been brought to you with complaints of empty scrotal sacs. Yes, the child is having empty scrotal sacs, and investigations reveal that the right-sided testis which is there, it is inside the pelvic cavity, and the left one is in the inguinal canal basically. What is the likely diagnosis? So I hope all of you are quite aware, whenever there are empty scrotal sacs, there are two possibilities. Either the testis will be undescended, okay, or it will be ectopic. We know whenever the testis gets arrested in the normal path of descent, agar normal raste mein kahin atak jati hai, that is an undescended testis. That means if the testis is in the abdomen, inguinal canal, or in the scrotum, then we call it as undescended testis. But if the testis is out of these pathway, then it is an ectopic testis basically. Now let me know in the chat box what is the best answer. Option A says cryptorchidism, that is a bilaterally undescended testis. Option B says right is undescended and the left one is ectopic. Option C says left is undescended and right is ectopic. And option D says both are going to be ectopic. So let me know what is the answer. If I talk about undescended testis, I hope all of you are quite aware. Undescended testis bilaterally is known as cryptorchidism. Crypto means hidden. Most common site for an undescended testis is inguinal canal. The commonest site for an undescended testis is the inguinal canal, and the investigation of choice will be an ultrasound. Okay, investigation of choice is usually an ultrasound, but in few cases when you cannot confirm the diagnosis on an ultrasound, you have to go for a laparoscopy. Okay, so if the undescended testis is in the inguinal canal, you can diagnose by ultrasound, but if it is somewhere else, then you have to go for a laparoscopy only beta. We know whenever a child is brought to you with undescended testis before 6 months of age, the treatment is only observation, wait and watch, or reassurance, whatever you say. Reason, majority testis will descend down spontaneously within 6 to 9 months. अपने आप नीचे आ जाते हैं 6 से 9 महीने में. ठीक है? So up to 6 months, never go for any treatment, never go for any surgery. It is only observation or reassurance that is done up to 6 months. Between 6 to 18 months, that is the best time to do a surgery, and between 6 to 18 months you do a orchidopexy. After 6 months of age up to 18 months, you can do an orchidopexy or fixation. Okay, so here now I hope all of you have answered your very good. So we know here they are saying beta that the right sided testis is in the pelvic cavity. We know right sided testis is in the pelvic cavity. That means the right sided testis is ectopic basically, whereas left sided testis is inside the inguinal canal. So we know left sided testis, if it is in the inguinal canal, it is an undescended testis. So here the answer is option C, that is the left testis is undescended and the right one is ectopic. This is a very common question repeated in the FMGE exam twice or thrice almost, to be aware of this. Next is question number 94. Here they are saying that we are having an elderly male who was diagnosed with prostate cancer and has been brought to you with complaints of low back ache. Workup reveals there is an osteoblastic metastasis to the lumbar vertebrae. What is the likely route of spread? So I hope all of you are quite aware. See, whenever an elderly male is brought to you with complaints of a low backache along with a lower urinary tract symptoms like increased frequency, nocturia, hesitancy, intermittency, all of this. So then please think about a metastatic prostate cancer or an advanced prostate cancer. समझे बात? So here the elderly male is having a prostate cancer which has spread or which has metastasized. We know prostate cancer is commonly known to cause an osteoblastic metastasis. We know majority cancers or malignancies, when they spread to bone, they cause an osteolytic metastasis, but prostate cancer is the one which commonly causes an osteoblastic metastasis, and the most common site of spread is the lumbar vertebra. That leads to low backache. तो याद रखना, either they ask you about the prostate cancer or they ask you about breast cancer. In prostate and breast cancer, both the conditions, do remember, the most common site for distant metastasis is the lumbar vertebra. Most common site for distant mets is the lumbar vertebra. Prostate cancer commonly causes an osteoblastic metastasis, whereas breast cancer commonly causes an osteolytic metastasis. Clear? And if they ask you what is the route of spread, for both the cancer spreads to the lumbar vertebra with the help of this Battison's plexus of veins. So Battison's plexus of veins is the route via which the cancer spreads to the lumbar vertebrae. So answer has to be option A, that is vein beta. ठीक है, this was a recent Jan question in FMGE examination last Jan. ठीक है, तो artery, lymphatics, nerve, they are not the route. It is mainly option A, that is the vein is the route of spread. Very good. Next, if I talk about now question number 95, here they are saying we are having a homosexual man who complains of painful defecation and a mass is protruding from the patient's anal canal. Now they are asking you on biopsy, a squamous cell carcinoma of anal canal has been confirmed. So we know it is a case of an anal cancer or an anal canal cancer, and we know in anal cancer it is mainly a squamous cell carcinoma which is going to be seen. Okay, what is the most appropriate management they are asking you? What is the answer? Let me know in the chat box. Option A says a surgery known as abdominoperineal resection. Option B says a low anterior resection. Option C says chemoradiation, or option D says surgery followed by a chemoradiation. Let me know in the chat box. So we know here they are saying the patient is a homosexual man. We know in homosexual man there would be a high risk of sexually transmitted infections like HPV, that is human papilloma virus. So human papilloma virus 16 and 18, okay, they are going to increase the risk of oral cancer, laryngeal cancer, cervical cancer, and anogenital cancer. Okay, again remember, HPV 16 and 18 increases the risk of oral cancer, laryngeal cancer, cervical cancer, and anogenital cancer. That is squamous cell carcinoma mainly. So yes, we know, as there would have been a HPV infection, the patient was diagnosed with anal cancer, and anal cancer is a squamous cell carcinoma which is seen. Now in this condition, if they ask you what will be seen on biopsy, we know investigation of choice is biopsy, and biopsy in squamous cell carcinoma classically shows you the keratin pulse. In any squamous cell carcinoma of the body, usually you will find the keratin pulse on the histopath or the biopsy. If they ask you what is the most appropriate management, I hope all of you are quite aware. The most appropriate management in this condition is answer option C, that is chemoradiation. Yes, chemoradiation, which is usually given via the Negro's regime. That is the best treatment for a case of anal cancer. Reason, in anal cancer, if you go for a surgery beta like abdominoperineal resection, we know the sphincters will get damaged, and if the sphincters will get damaged permanently, patient will have a fecal incontinence or an anal incontinence. So इसीलिए we don't prefer a surgery in anal cancers. In anal cancer we usually go for a chemoradiation, and that is given with the help of a Negro's regime. That is what is important to be remembered in the examination. Clear about that? Has been a PYQ, so be aware of that. Chemoradiation or Negro's regime. Clear? Next is question number 96. Here we are able to see there is a young male who was brought to you with complaints of recurrent hypoglycemic episodes. So patient is having hypoglycemia or low blood glucose again and again. So there is a recurrent hypoglycemic episodes, and glucose administration helps improve the patient's condition. So I hope all of you are quite aware beta. Here glucose, if you give to the patient condition improves basically. So glucose administration improves the patient's condition. Okay, they are asking you what shall be the best investigation to confirm the diagnosis in this case. What is the likely diagnosis you can think about over here? Let me know in the chat box. What is the likely diagnosis you can think? I hope all of you are quite aware. Here you will be able to see the classical Whipple stride beta. The Whipple stride is patient is going to have recurrent hypoglycemic episodes or recurrent hypoglycemic attacks basically, where the patient will have dizziness, headache, palpitations, tremors, diaphoresis, these kind of symptoms. Second important, the patient is going to have a blood glucose less than 40 milligrams per deciliter. Few books say less than 45, it's fine. So less than 45 or less than 40 milligrams per deciliter. And third important, patient will have improvement in the symptoms after you give glucose or after you administer glucose. This is known as Whipple stride. Okay, and I hope all of you are quite aware. Whipple stride is basically seen. Very good. Whipple stride is a classical feature of insulinoma. Insulinoma is the most common functional pancreatic neuroendocrine tumor. The most common functional pancreatic endocrine tumor. Sorry, the most common functional pancreatic neuroendocrine tumor is insulinoma. Majority cases of insulinoma we know are going to be benign in nature. 90% cases of insulinoma are usually benign in nature. And as this is a tumor arising from beta cells, it secretes a lot of insulin. And this excess insulin is basically known to cause recurrent hypoglycemia in the patient or the classical Whipple stride. In insulinoma, do remember the gold standard investigation or the best investigation is option A, that is a fasting insulin by glucagon ratio. Either you can only check for the fasting insulin levels. You know, normally in fasting the insulin level should be low, but if the patient is suffering from insulinoma, even during fasting the insulin levels are high, and that proves your diagnosis. Clear about? So the best investigation is basically a fasting insulin levels or fasting insulin by glucagon ratio that has to be done. Okay, whereas do remember for diagnosing the tumor or to localizing the tumor, we can do for a somatostatin receptor scintigraphy or endoscopic ultrasound. So commonly we use an endoscopic ultrasound if I want to localize the tumor basically. Okay, an endoscopic ultrasound is commonly used to localize the tumor or an insulinoma. Serum gastrin levels are done in a patient of gastrinoma. And in gastrinoma, the patient will not have Whipple stride or hypoglycemia. In gastrinoma, patient has recurrent peptic ulcers. Clear about? Treatment for an insulinoma, we know the drug of choice that we use in insulinoma is diazoxide. Diazoxide is known to decrease the insulin secretion, and the surgery that we do, if the insulinoma is seen in the head of pancreas, we only remove the tumor called as enucleation. In the head, we only remove the tumor called as enucleation. But if that insulinoma is in the tail of pancreas, if the insulinoma is in the tail, then we have to remove the distal pancreas called as distal pancreatectomy. Clear about? Do remember another question that comes is basically from a gastrinoma. Recent question in the FMGE examination was from a gastrinoma. Do remember gastrinoma, most common site is the Passaro triangle or the gastrinoma triangle. Most common site for a gastrinoma is the Passaro triangle or the gastrinoma triangle, which includes the common bile duct, the duodenum, and the head and neck of pancreas. Now, among them, if they ask you what is more common, so it is not the pancreas, it is the duodenum. Yaad rakhna, in the Passaro or the gastrinoma triangle, the most common site for a gastrinoma is not the pancreas, it is the duodenum. Yaad rakhna hai baat. And here, as it is a tumor of G cells, it causes increased gastrin secretion, and as there is more amount of gastrin, there will be more HCl secretion, and excess HCl secretion will lead to formation of recurrent peptic ulcers or giant peptic ulcers, which are going to be seen in this patient. Okay. Whereas best investigation to confirm a diagnosis of gastrinoma was the recent question in the examination, and that is serum gastrin levels more than 1000 picograms per ml. Okay. So best investigation to confirm the diagnosis is serum gastrin more than 1000 picograms per ml. Drug of choice for gastrinoma are PPI or proton pump inhibitors like prazoles. So PPIs or prazoles are the drug of choice for a gastrinoma, and treatment is a surgery. Okay. Chalo. Next is question number 97. Okay, we know here we are having an elderly smoker patient who presents to us with complaints of gangrenous toe, as you are able to see in the picture. If you see the picture, there is complete gangrene of the toes which are going to be seen, and they are saying the patient had a history of rest pain and ulcerations at the same site earlier. Obviously the patient would have had intermittent claudication initially. Later on the patient would have rest pain when the nerves would have died. Next, the patient would have numbness or ulcerations, that is pre-gangrene, and lastly there is complete necrosis or gangrene, as I've told you, right? The patient is also giving you a history of stroke few years ago. What is the likely diagnosis? So please tell me, if they ask you there is an elderly smoker who comes to you with gangrene or gangrenous toe with a history of rest pain or pre-gangrene earlier, it is a classical diagnosis of. Very good. Yes. The answer to this question is not option A, that is option B basically, that is atherosclerosis, right? I hope all of you are quite aware, and the most important factor being the age of the patient. Yaad rakhna, smoking is not only associated with Burgess disease, smoking is also associated with atherosclerosis. It is a risk factor for both, yaad rakhna. But we know that Burgess disease which is there, it is always common in younger patients who are usually less than 40 to 45 years of age. So younger patients less than 40 or 45, in those conditions, Burgess disease is common, whereas atherosclerosis is more common in elderly patient more than 50 years of age. Okay, so that is the basic and the most important difference between the two. So here, as they said, elderly smoker along with gangrene, think about atherosclerosis, which is the most common cause of gradual arterial obstruction. Whether they say atherosclerosis or Burgess, we know in both the condition, patient will have lower limb blockage. That means there will be blockage of the arteries in the lower limbs commonly, whether it is atherosclerosis or it is Burgess disease. The most common vessel that is blocked in atherosclerosis is abdominal aorta. In atherosclerosis, the most common vessel blocked is abdominal aorta, and the most common peripheral vessel blocked is popliteal artery PYQ. Most common peripheral vessel blocked in atherosclerosis is the popliteal artery. Whereas investigation of choice, we know for all the peripheral vessels, the investigation of choice will be a duplex scan or a color Doppler. Treatment of atherosclerosis, initially you will give lifestyle modifications. Whenever you advise lifestyle modification is quit smoking and alcohol, obviously. Okay. The patient has to quit smoking and alcohol, and the patient has to do regular exercise. If lifestyle modifications don't help, then you go for medical management, that is vasodilators, antiplatelets and statins. The three drugs that you prescribe in medical management for atherosclerosis or Burgess disease is vasodilators like cilastazol or pentoxifylline. Yes, cilastazol or pentoxifylline, antiplatelets and the statins. Next is, if medical management also fails, go for an angioplasty. Either you go for a balloon angioplasty to break the atherosclerotic plaque or a stent angioplasty. So either a balloon or a stent angioplasty is basically done basically beta. And last is bypass grafting. The last option is a bypass grafting. Do remember, when you do a bypass grafting, either you can use a autologous graft from your own body or you can use a synthetic graft. If they ask you what is the best autologous graft used, so yaad rakhna, the best autologous graft that we use from body is the IMA or the internal mammary artery. It is IMA or the internal mammary artery. So Lima or Rima we call it as. That is the left internal mammary artery or the right internal mammary artery. That is Lima or Rima. They are considered as the best autologous graft in bypass grafting. Whereas the most commonly used autologous graft, if they ask you, answer is GSV or the great saphenous vein. The most commonly used autologous graft, if they ask you, answer is GSV, that is the great saphenous vein basically, because it is easier to take. The best one, if they ask you, answer is IMA. Most common one, if they ask you, answer is great saphenous vein. Clear? We know aneurysm basically presents to you with a pulsatile swelling. Aneurysm commonly presents to you with a pulsatile swelling. Pulsatile swelling bolenge, think about either an aneurysm or a AV fistula. AV fistula and aneurysm has pulsatile swelling. Okay? Oh, varicose veins basically they cause a dilated veins initially, we know. Question number 98. Here they are saying a middle-aged man who works in the PWD department or the public welfare department is and drills the roads now presents to you with complaints of color changes in the tips of fingers as shown below. What is the likely diagnosis? So here you are able to see initially the patient is having complete pallor or white fingers that you are able to see. Secondly, you are able to see bluish fingers or cyanotic fingers which are seen. So initially the fingers are turning white in color, later on they are turning blue in color. So the color sequence is W, B, R, that is white, blue and red. And I hope all of you are quite aware it happens due to the spasm of the vessels in the tip of fingers or the tip of toes. That means whenever the vessels in the tip of fingers or the tip of toes undergo a spasm, these changes are going to be seen. The color changes are white, blue, red, WBR. Okay. Now let me know what is the cause. To we know the important risk factor over here is drilling the roads. Okay. As the person drills the roads, there is a prolonged vibration. Okay, and due to that the patient may develop this problem basically. Okay, so two important risk factors for this condition, one is cold exposure and second is prolonged vibration. Cold exposure and prolonged vibration increases the risk of this condition. We know this is nothing else but a case of Raynaud's phenomena. But we know there are two types of Raynaud's phenomena. The first one is called as primary Raynaud's phenomena, also known as Raynaud's disease. The first one is known as a primary Raynaud's phenomena or Raynaud's disease, whereas the second one is a secondary Raynaud's phenomena, which is associated with some comorbidities or some disorders. What is the answer to this question? Option A or option B? This is the last session and last one or two questions are left now. There are total three sessions, bache. This is the last session. Other two sessions have been taken and they have been uploaded already. Please tell me answer क्या होगा इस केस का. I hope all of you are quite aware. Do remember, primary Raynaud's phenomena or Raynaud's disease is when the cause is unknown. So whenever the cause is unknown or whenever the cause is idiopathic, so whenever the cause is unknown or whenever the cause is idiopathic, we know it is called as a primary Raynaud's phenomena. Whereas whenever it is associated with some connective tissue disorders like SLE or scleroderma, so whenever it is associated with connective tissue disorders, we call it a secondary Raynaud's phenomenon. Yaad rakhna, here they have not spoken about any connective tissue disorder or any other disease in the patient, so it cannot be a secondary Raynaud's phenomenon. Here the answer has to be option A, that is Raynaud's disease, that is also known as primary Raynaud's phenomenon, because the cause is idiopathic over here. Risk factor is there, but cause is idiopathic. There is no disease in the patient. That's the reason. AV fistula, as I've told you, a classical pulsatile swelling. In a PYQ, when there was a question, they said patient comes to you with dilatation of a vein after a trauma. Okay, but a lot of people marked answer as varicose vein. You know, dilated vein is a varicose vein in leg, but it does not have any pulsatile swelling. If they mention pulsatile swelling of a vein, think about an AV fistula or an arteriovenous fistula. Venous insufficiency is not the cause. So treatment in cases of Raynaud's phenomena, we know initially you can go for lifestyle modifications, that is ask the patient to avoid the risk factors, and secondly to wear warm clothing. But the drug of choice is CCBs or calcium channel blockers. So vasodilators like CCBs or calcium channel blockers are the drug of choice for Raynaud's. Next, question number 99, easy repeated question in the exam. We are having a young male who presents to us with complaints of abdominal pain and renal stones. Okay, so he was investigated for a parathyroid adenoma. We know that whenever there is hyperparathyroidism or increased parathyroid hormone levels, patient will have hypercalcemia, and due to that hypercalcemia, patient is having problems like abdominal pain or renal stones. That's the reason the patient might have been investigated for a parathyroid adenoma, because due to parathyroid adenoma, the patient will develop hyperparathyroidism, and that would be the reason for hypercalcemia causing this abdominal pain or renal stones basically. So now they are asking you that what is the best investigation to diagnose this condition. If you want to diagnose a case of a parathyroid adenoma, what is going to be the best investigation out of all the options that are given? Option A says technetium 99 per technate scan. Option B says CECT neck. Option C says radioisotope scan. And option D says system EP scan. I hope all of you are quite aware. Answer to this question is basically let me know in the chat box. What do you feel is the answer for this question? Let me know. We know beta that CECT neck which is there, that is usually done for thyroid swellings or parathyroid swellings, but it is not the investigation of choice to confirm if it is a parathyroid adenoma. Second, radioisotope scan, again it is done for thyroid basically, not for a parathyroid gland. Okay. Now we are left with technetium 99 per technate scan or system MB scan. We know yesterday we have discussed technetium 99 per technate scan is generally done for Meckel's diverticulum. So answer to this question is nothing else but option D, that is a system EB scan. Either a SPECT system EB scan can be done or a technetium 99 system EB scan. That is the reason I ask you not to remember technetium 99. Technetium 99 is an isotope, bhai. It can be used for any nuclear scan. Clear about? So if it is a per technate scan, then the answer is Meckel's diverticulum. If it is a system EB scan, then it is a parathyroid gland pathology or a parathyroid adenoma. Samjhe baat? That has to be remembered. Do not make any mistake over here. And last question, question number 100, that is what is the radioisotope of iodine that has to be used in the brachytherapy of prostate cancer? We know in prostate cancer, especially in the advanced stages, we either go for an hormonal therapy, or we go for a radiotherapy, that is brachytherapy. And in brachytherapy of prostate cancer, which radioisotope of iodine has to be used? Which radioisotope of iodine is used for the management of prostate cancer? That was a PYQ in June 2022 examination. We know the radioactive iodine which is there, it is going to emit the beta rays. This is important. The destruction of the cells is caused by radioactive iodine, mainly by the beta rays, and it is used to treat hyperthyroidism. We know 98 to 99% of the body's iodine is taken up by the thyroid gland. So once this radioactive iodine goes inside the thyroid gland, it will emit this beta rays and it will destroy the thyroid follicles. So it will help you to treat a case of hyperthyroidism. Do remember, it is contraindicated if the female is pregnant. Obviously radiations are contraindicated, or if the patient is a small child. So in pregnancy and children, radioactive iodine scan or the radioactive iodine therapy, they are contraindicated. That has to be kept in mind. याद रखना, if I talk about the various forms or various radioisotopes of iodine, we know the radioactive iodine 120, the radioactive iodine 131, it is generally used for treatment. So radioactive iodine 131 is generally used for therapeutic purposes or treatment. It has a longer half-life of around 8 days. It has a longer half-life of 8 days. Secondly, radioactive iodine 123 is the most common one used for diagnosis. The most common radioactive iodine or the isotope of iodine used for diagnosis is iodine 123. The radioactive iodine 123 is the most common one used for diagnosis with a half-life of only 13 hours. Clear about? Whereas 125 and 127, they're also used for diagnosis, but they're not the common ones basically. Okay, so that is important. But if they ask you what is the one that is used for brachytherapy in prostate cancer, I hope all of you know about this PYQ and the FMG. Answer is option C, that is iodine 125. Yes, radioactive iodine 125 is commonly used for the diagnosis of thyroid related problems, but it can also be used for treatment of prostate cancer or brachytherapy of prostate cancer. That is an exception to be remembered. याद रखना ये बात, ठीक है? So these are the points that you need to remember basically about the radioactive iodine. These are the points that have to be kept in mind. Chalo. So that was all about the most expected MCQs in surgery. Okay. So as I always say, definitely at this point of time, what you need to have is the self belief. And if you are going to believe in yourself, anything is going to be possible. Don't worry about the examination. Do not think that how the examination questions are going to be, how the exam is going to be, what the results are going to be. ये देखो, तुम्हारे हाथ में मेहनत करना है, तुम मेहनत कर रहे हो, तुमने मेहनत की है. तो अभी एग्जाम कैसा आएगा और रिजल्ट कैसा आएगा वो बाकी सब डेफिनेटली डेस्टिनी पे छोड़ दो, अपने नसीब पे छोड़ दो. डू नॉट कीप ऑन थिंकिंग अबाउट दैट बिकॉज यू कैन नॉट चेंज इट. तो दोज थिंग्स वी कैन नॉट चेंज. क्वेश्चन कैसा आएगा ये तुम्हारे हाथ में नहीं है, रिजल्ट क्या होगा वो भी तुम्हारे हाथ में नहीं डायरेक्टली. ठीक है. सो बेसिकली डू नॉट थिंक अबाउट दैट. व्हाट इज मोर प्रैक्टिकल इज टू थिंक अबाउट दोज stuff that we can do something about. Obviously we can do something about studying, better do that. So now for the last few days, definitely beta, one thing is you have to make sure that you are solving MCQs on a daily basis, 9 to 11:30 and 2 to 4:30. In this time, any time, basically you can solve around 100 150 questions on a daily basis minimum. इससे ज़्यादा कर रहे हो तो that's fine basically, no issues with that. ठीक है. So that is one thing to be done basically. Second important thing is going to be at this point of time, you have to make sure that those who have attended QRS, make sure you are revising QRS alongside, or at least in the last 2 days, you are going to revise QRS properly and thoroughly. Okay. And at this point, at least those subjects where you are making maximum mistakes or those subjects which are going wrong again and again, at least try to go back to the notes of that subject. If you have a proper schedule that you are following, follow that schedule. But if you are not having a proper schedule, you are confused what has to be studied, so yaad rakhna, in if you have completed 2 revisions of all the subjects, then make sure at least those subjects where maximum mistakes are happening, you are picking up those subjects again. Do not pick that subject for a line to line revision. That's not practically possible at this time. What is possible with practically is just going through the important topics or the previous year topics of that subject, or revising those topics which you are making a repetitive mistakes at. तो जहां भी गलतियां बार बार हो रही है, उन टॉपिक्स को बस वापस देखना एक बार. That is what is more important, I feel. ठीक है. Solve all the PYQs basically of FMG and NEET PG. Try to cover them as early as possible. Read the explanation at least for the wrong questions. That is what is important to be remembered. Hopefully clear. ठीक है. So these are the few things that you have to do. Do not worry much. Okay, just chill out, and examination is going to be in your favor. Results are definitely going to be in your favor. Okay, as I always say, the last lap of the battlefield is on. So as you are warriors, you have to pull up your socks. You have to be ready for the battlefield, and if you're anxious, you'll not be able to win the battle. ठीक है. तो just be calm and composed at this point of time. Anxiety होगी, but वो तुम्हारे हाथ में control कैसे करनी है. ठीक है. तो बस कंट्रोल कर लो एंजाइटी को. ऑब्वियसली टॉक टू पीपल, टॉक टू फ्रेंड्स हु विल डेफिनेटली हेल्प यू टू बूस्ट योर मोरल or to boost your confidence. Don't talk to those people who are going to lower down your morale at this point of time. जरूरत नहीं है ऐसे लोगों की अभी. ठीक है, तो talk to your family, talk to friends, talk to faculties who will definitely push you at this point of time. Does not matter कितना पढ़ा है, भूल जाओ उसके बारे में. जो भी पढ़ा है, जैसा भी पढ़ा है, होगा एग्जाम. इतना कॉन्फिडेंस अभी इस पॉइंट पे होना चाहिए. आई एम नॉट सेइंग अबाउट ओवर कॉन्फिडेंस, but I'm talking about a basic confidence that we need to have beta. Otherwise तो we'll get depressed in the exam. ठीक है, so we don't have to be depressed. आराम से हो जाता है एग्जाम. I have done it and I know you are all going to do it. ठीक है, चलो, all the very best from my side. Lots of love. Thank you so much. Take care and best wishes. Before the examination, be updated in my Telegram group. I'll be taking a session so that your anxiety would lower down somewhat. And secondly, definitely me and Dr. Vikas would come live basically with a session so that your anxiety lowers down somewhat, and we will discuss the do's and don'ts for the examination. ठीक है, तो in my Telegram group I'll update the timing. ठीक है, चलो बेटा, it's always a pleasure to work for all of you and all the very best for the examination. Take care.